one it's just but we'll go back one there. Don't have anything to disclose is all that really says. But wanted to talk to you today about because I think I am partway in my talk too. Can you restart it? This is about my 8th slide, I think. There you go. Thank you. Exactly. There we go. I don't have anything to disclose. This curriculum is really partnered between American College of Surgeons and Association for Surgical Education. And students have really been caught in the quality movement that most of you are very well known, that they are still expected to learn everything. They have much fewer opportunities to do it than what we had when we were training. But yet they are still expected to know this on day one of their residency, as exemplified by the AAMC's recent release of their entrustable professional activities for entering residency. It is not appropriate for them to practice on patients, and students are really caught in the middle of this patient safety era. As we move on, how do we overcome these gaps in student education and expectations? Provide a good product for residency training. As program director, one of my other hats, I want really good students to come to my program. Obviously, the answer is simulation. So one way to address this is the American College of Surgeons and Association for Surgical Education, of which many of the people in this program are also SAGES members, started back several years on designing a medical student simulation skills-based curriculum. It really began in 2009. The college joined in 2010. We authored modules and released it in 2014. It's a national simulation-based skills module set. It's meant to be universal for all physicians so that anyone finishing medical school will have a basic set of education, as we are identifying they have fewer opportunities to do this. And it is really reproducible, and we have an assessment more as a feedback for our students. It really mimics the entrustable core professional activities by the AAMC. They have 13 cores that were developed in a parallel session, not necessarily combined, but very much parallel, and was released in 2014 as well. We really match up with 6 of them quite nicely, and a lot of ours are lumped under EPA number 12. Designs of the modules are meant to be uniform. Our learner now in the millennium really wants everything sort of packaged and uniform. They look the same as they go through all the modules. There's a standard template. It's based off of the APDS curriculum slightly. And there's a key is there are assessments with every single one of the modules. They can be done as individuals or in small or large groups, and the models are very inexpensive. They have extremely low fidelity. If you start to balloon this out across all of medical schools throughout our country in North America and throughout the world, it could become extraordinarily expensive with many of the high fidelity models that we have. It's meant to be portable, can be done in simulation center, classrooms, or in a clinic space, or even in large banquet halls such as this. The design of the evaluations, they're not designed to imply competency. They're merely designed mostly as a self-improvement tool for our students, that they can look through it, they can grow from it, and has a checklist and a global rating score. We did survey a lot of clerkship directors throughout the country in North America. We initially had 42 skill modules listed and a 5-point Likert scale, and we pared that down to roughly to 25 or 30 through the first 3 years. When we surveyed medical students, they admitted none of them, and they wanted them all almost in their first couple years of school. These are the modules as currently we have them. There are 8 within the first year. You see most of those are physical exam type modules, those skills that an early medical student would be expected to know, and those initial clinical evaluations or clinical experiences. As year 2 modules, a little bit more advanced. Some maybe in some coding aspects, and one of my favorites is sterile technique and gloving and gowning. I feel strongly that every physician should know how to glove and gown themselves from an infectious disease standpoint and patient care and safety. In our year 3 modules, more are the ones that we think about classic surgical type procedures. This is just an example of one of the modules that you can see. We chose the central venous line insertion, and it goes through, as I know it's a little hard to read, and I apologize for that. Almost everyone says that, and we all say, why did you do it then? But we have our objectives, our assumptions, suggested readings that we have in there, and then we march through the module as we go through it, the different steps, and most of them have photos in that as well. And then we have common errors. It's really important that we list the errors for our student and our learners so they don't reproduce those errors as they come through it. And then my favorite part of all of them is the assessment tool that comes with it. There's a nice initial explanations for our faculty to do some faculty development at your site, and then we get in the meat of it. Every single one of them has a checklist included, as well as a global rating tool to give back to our students as they come along. We've tested it in several different ways, and I'll present some of that data. We've used very large formats at the Clinical Congress the last couple of years. Last time in 2014, we chose one-handed knot ties, because we figured most medical students aren't necessarily taught how to do that. We've beta testing it at 10 programs, and we've been able to show sustained visits to the website and downloads of the curriculum. At 2014, I don't quite have the 15 data up, but we have the 2014 data. We had 134 students that went through the one-handed knot tying module. We were able to brief and teach our faculty just 15 minutes before the session, and we followed the one-handed module quite well. Most of the students had described they hadn't even been taught one-handed knot ties. A few had done it less than 5 times. Most reported they had no comfort in doing that. Upon completion, 75% of them reported being moderately very comfortable, and the assessment by the instructors bore that out, that they were able to not master the skill, but they were able to learn it in a reasonable time frame over about 20 minutes in a large conference room. If more specifically, we've used our basic AIRWAY module through 10 of those schools, and this is the data over the last year from those sites that most of the students coming in as third-year students have very little self-reporting experience with managing an AIRWAY, but then most of them within utilizing the module as it's written can manage an AIRWAY satisfactorily upon the end of that. Not necessarily in a clinical setting or an emergent setting, but at least in a controlled simulation setting, they now at least know the steps that they did not know before to manage a basic human AIRWAY. These is an exemplification or grafting of the visits to the site, where it generally have about 400 visits to the curriculum database every month, and roughly about 4,500 annually the last couple of years since it's released. The blue bars, there's 2013 when we sort of had a soft release, then it starts back in the red in 2014. So our next steps is to continue to popularize the curriculum. It is open and can be downloaded by anyone with the American College of Surgeons user ID and name, and you can get one specifically for the curriculum if you don't belong to the college. As we want it to be supported by a broad group of educators, not necessarily surgeons, but everyone within our medical schools. We'd love to get more feedback on the modules, improve it, make it better, revise them, and are looking to add some year 4 skills, more advanced bedside skills or surgical skills as we move forward. And really our goal is to have deliberate teaching of the needed skills that we feel every person finishing medical school in the United States should be able to do. Society still expects it of us. In summary, students are still expected to learn these skills. Simulation really is the way to teach them. They don't get the experiences on the bedside wards. It's been documented in several studies, but yet they're still expected to start the residency knowing how to do that. We still expect it of them as program directors. I do think in the end it really will improve quality. I don't have any data to say that it does, but anecdotally we've gotten reports back from students that they do learn more and that they seem to be starting the residencies a little bit better. I think some of the boot camps suggest that same need, and simulation can help support these students. So thank you.